Hey guys, I'm pre-recording this for you to watch on your own time, because we do have accreditation meetings and I don't want to get behind in classes. Um, we're going to go over chapter 23, the shoulder today. And I mean, it's a pretty complex subject. The shoulder has a lot of working parts to it. So this lecture that you're getting today, there's going to be some additional assignments that you're going to have with it. One being the quick dash. The when you complete the quick dash, I want you to complete it on one of your classmates. Um, and the person that is pretending to be the patient needs to pretend like they've had a shoulder injury, a recent shoulder injury. Don't be perfect, in other words. Give the practitioner something to work with, something to score. So keep that in mind. And I'll also send this information out in a message. So orthopedic considerations and the shoulder. Um, when you're reading chapter 23, it's going to introduce you to the shoulder, and you're going to see some of the complex anatomy that deals with the shoulder. The shoulder is actually one of my favorite subjects to teach, and it's I guess because it's just so complex. There's like so much to learn about it. We're going to look at it in this chapter, but we'll also revisit certain concepts um, in other chapters, especially chapter 33 when we talk about CVAs. So, your learning outcomes for this chapter, you want to describe the anatomical and the biomechanical considerations in shoulder treatment, describe common shoulder orthopedic conditions, and different interventions that to treat that. We're going to discuss the evaluation process for shoulder conditions, the unique role of OT in the management of shoulder orthopedic conditions, and the intervention approaches and methods and precautions. Um, for this chapter, normally we have been just kind of focusing on the interventions, but where the shoulder is so complex, I'm going to do the full lecture, um, and hopefully you'll be able to rewatch this, pause it when you need to, start it when you need to. So some self-assessment activities. You can watch some videos about common shoulder surgeries. Rotator cuff repair and shoulder replacement are two of the most common. So you do need to know, have a little bit of an idea about those. You also need to know the range of motion and what movements the shoulder performs in your everyday activities. People don't think of the shoulder as being so important, but it really is to your everyday, everything that you do. So, some shoulder anatomy and biomechanics. The shoulder has three ranges of motion in all planes. It has flexion, extension, ab and adduction, and rotational movements. Um, So it's in all three planes around all three axes. There's three different joints that go along with the shoulder, and I will show you those at a later time on the skeleton. But these are synovial joints. And if you'll remember from kinesiology, synovial joints are also called diarthrodial joints. And those are the joints that have a synovial capsule inside of them. Okay. Um, so the the joints are the sternoclavicular, and if you think about the name, you'll think about you can realize where the joint is. Okay, so the sternoclavicular would be the joint between the sternum and the clavicle. The acromioclavicular is the joint between the acromion process and the clavicle. And then you've got the glenohumeral joint, which is the joint between the glenoid fossa and the humerus. Um, so the scapula glides over the thorax, and it's essential in the dynamic stability of, and is intimately linked to the function of the glenohumeral joint. So for instance, when the humerus moves into shoulder flexion, the motion of the scapula, which is upward rotation, increases. This causes alterations in the stability and positioning of the scapula, and it can cause functional disruptions in the glenohumeral movements. Um, and the glenohumeral movements are also called scapulohumeral rhythm. Uh, okay, so if you look at table 23, 23.2, I'm sorry, there's different movements that we'll be going over and that you have to know, that are created at the shoulder. Um, you can go ahead and try the movements, and if you don't know them, we will be going over them at a later time. You also need to be aware of the muscles and the movements they produce along with each corresponding joint. And as you are thinking about this, I want you to think about the movements you do every day and which muscles may be involved in those movements. Okay, so think about, which movement are you doing when you're washing your hair, and which muscles are involved in that. Same with buttoning your pants or putting on a shirt. Think about the motions that are occurring and which muscles are involved. Um, so some of the muscles that aid in shoulder movement include your serratus anterior. What that does is it fixes the scapula into the thoracic wall, and it aids in rotation and abduction. Then you've got your deltoid muscle, which has a different type of fiber. And the different fibers of the muscle are responsible for the different actions. Um, this includes the humeral flexion and abduction and assisting with the pectoralis muscles. Then you've got your levator scapula. The levator scapula will rotate the scapula downward, and it elevates the scapula. You got your pec major, that creates humeral flexion, internal rotation, and adduction. You've got your pec minor, which will medially rotate the scapula. It also protracts the scapula and moves the scapula down inferiorly. You've got your trapezius, which aids in scapular depression, upward rotation, elevation, and adduction. Your rhomboid major and minor, which aids in downward rotation and retraction of the scapula. Teres major, responsible for humeral adduction, internal rotation and extension. And then your latissimus dorsi, which is responsible for humeral adduction, internal rotation, and extension. And then you've got the rotator cuff muscles. Now, there are four rotator cuff muscles, so four muscles that make up the rotator cuff itself. It's your SITS, SITS muscle group. So you've got your supraspinatus, which it helps with humeral abduction within the first 15 degrees of movement. Then you have your infraspinatus, which aids in external rotation and it helps with shoulder stability. Then your teres minor, which is responsible for external rotation, and then your subscapularis, which is responsible for your internal rotation. And I know that's a lot of muscles right now. And, you don't really need to memorize them all right now, but you do need to have a good knowledge of them because you're going to see them again several times in different chapters. So what you'll need to know is the names of the muscles, where they're located, and what actions they perform. And the reason that you're going to need to know this is because when you have a patient that comes in that has some type of a shoulder injury, the motions that they are having trouble performing will determine the muscle that you're going to provide interventions for. Um, and that'll make much more sense once we do some of the activities in person. But it's important to get the lecture part down first. So you got some common soft tissue shoulder conditions that you're going to see. Now, shoulder pain is considered the third most common musculoskeletal condition after back and neck pain. Your rotator cuff muscles, your sits muscle group, they act as a coordinated group. They stabilize the humeral head during shoulder movement. They work to counterbalance the deltoid, which produces an upward movement of the humeral head during movements like flexion or abduction. And without this balance that's exerted by the rotator cuff muscles, the humeral head would impinge against and pivot on the coracoacromial arch during elevation. So basically what that boils down to is the rotator cuff muscles holds the humeral head in place during shoulder movements. If there's any instability in the rotator cuff, that'll cause pain and it will also damage the shoulder. You also can get chronic tears in the rotator cuff. Those are typically an extension of a shoulder impingement where like little micro tears or I cannot say this word, tendinosis leads, and that will lead to larger tears later on if you don't get something fixed. Usually an additional injury will accompany the shoulder in some type of an acute rotator cuff injury. I know anytime that I have ever worked with a patient on a rotator cuff injury, they have had to have seen a physician first and had an MRI. If you do any type of shoulder interventions with a rotator cuff and it has tears, if there's micro tears or even a full thickness tear, you can do a lot of damage to that shoulder, possibly cause the shoulder to just not, that arm to just be paralyzed. So always remember that the person has to see a physician first. Then you've got shoulder instability. That's another type of soft tissue shoulder condition. That's usually common in patients that have hyperlax joints, but it will also occur sometimes in patients that have normal joint laxity. They just have like loose ligaments. And that normally occurs in athletes, gymnasts, things like that, people that run. Um, and the most common mechanism for shoulder instability is a trauma resulting from falls, um, like I said, athletics, or some kind of work-related injury. So the objective of a shoulder surgery, whether it's an open surgery or an arthroscopic surgery, is to treat the shoulder instability, um, and to tighten the glenohumeral capsule. So you want to make sure that you don't over stress the shoulder, because what will happen is it will scar. And treating that glenohumeral um, capsule will be difficult if there's scarring that comes along with it. You can also have tendonitis, bursitis, impingement syndrome, um, tenodesis, things like that. You need to read about that. Um, and just keep in mind that an itis, any type of itis like the tendonitis, bursitis, arthritis, that really can't be fixed. The only thing that you can do for it is pain management. So, and there's interventions that we do for pain management and things like that, but we'll talk about that later. Another really common one that I've seen is an impingement syndrome, or it's also called adhesive capsulitis or frozen shoulder. This is when the synovial fluid of the glenohumeral joint gets inflamed, and the soft tissue becomes really thick with adhesions, and this causes a lot of pain. Well, where the frozen shoulder or the adhesive capsulitis comes in is where the person quits moving and it freezes. And I've had several patients that have had frozen shoulder. And sometimes they've got to go to the doctor to either have it um, unstuck. Sometimes they have to open it up and manually kind of break that adhesion. And then other times we can do what we call joint mobility, and just kind of break it up externally. But you have to be very careful when you're working with the shoulder, especially with the frozen shoulder, um, because you can do a lot of damage if you don't know what you're doing. So there are different stages to frozen shoulder. Stage 1 may mimic other rotator cuff injuries and is marked by pain at the end of the shoulder motion. Stage 2 is the freezing stage. This is where you'll hear a lot of complaints of a lot of pain, discomfort, and at least 25% loss of range of motion in two planes. Stage 3 is the frozen stage, where the shoulder is significantly stiff but with less discomfort. Stage 4 is the thawing stage, where the stiffness remains, but the joint may be stretched with the least amount of discomfort. Normally, in stages 1 and 2 are generally just pain management with some range of motion when it's possible. They're usually in a whole lot of pain with stages 1 and 2. And then increased range of motion as tolerated in stages 3 and 4. Um, there's also some other stuff that goes on with some common bone and nerve and shoulder conditions. Fractures, brachial plexus injuries, cervical radiculopathy. So a foosh is one that you really need to know about. This happens quite a bit, usually in older adults, but it can happen with anybody. It's the result of a fall on an outstretched hand. Okay, it's an FOOSH. Stands for fall on outstretched hand. So usually it's a complex or a displaced fracture. Normally it's treated with immobilization and a sling for 4 to 6 weeks. Um, if it's non-displaced, then they're immobile for about 1 to 3 weeks. Those are less common, but non-displaced isn't quite as severe as a displaced one. So normally non-operative, they usually don't have to operate. Conservative treatment. Um, as a general rule, one of the main goals that are set for a FOOSH is an early goal of establishing like active motion with normal joint kinematics, while it's protecting the healing structures, and facilitating the healing process. The physician, you'll have to have a lot of communication with the physician. Now, a lot of times you will see these in outpatient. Every now and then you will see them in skilled nursing facilities. But most likely it's not a traumatic event, so you won't see it as much in hospitals and things like that. But the FOOSH, especially around this area, is very common, mainly because of just the way our landscape and the structure of our land is, where it's not even and things like that. And especially during the wintertime, people will trip on ice, fall on ice. And the first thing they want to do is stick that hand out. Um, so surgical decisions are normally based on the status of an injury, and then the extent of the involvement. Also, they'll look at the client's health status, their age, lifestyle, the impact that this type of shoulder surgery, or even this type of injury is going to have on the person's overall health, their well-being, and their quality of life. Um, Normally, surgeons or doctors will opt for conservative treatments or at-home exercise programs, and then balancing rest and exercise. Um, there's different types of surgery. There's arthroscopy, which is just a small incision. It has less healing time. This is usually the one that most people opt for. Arthroplasty, which is replacement of a joint. Um, Normally, repairs are done on very complex cases, and it will usually result in a replacement or an arthroplasty. Um, Also, if you've got a swollen glenohumeral capsule, or one that is that your shoulder, your the head of your humerus has came out of your glenohumeral fossa, they will do a thermal procedure, or that will shrink that glenohumeral capsule. Um, that doesn't, I haven't seen that before, but I mean, I guess it happens. Um, that is normally, they usually do that for non-traumatic shoulder instabilities, or frequent dislocations. But I've worked with mainly older adults, so I haven't really seen that. So when you're working with the OT and they're doing an evaluation on a shoulder, these are some of the questions that they're going to look at. They are going to want to do a history and intake information. If you look at, let's see, table 23.4, which is 598, page 598. These are a few of the different types of tests that are done, when we're looking at the shoulder. So what do you think that you should be looking for Think about that. What things should you look for during an evaluation for a shoulder? Um, One thing you're going to want to look for is, are they moving it? Is it moving in all three planes? Does it have full range of motion, partial range of motion, or are they holding their arm tight to their body and just not moving their shoulder at all? Um, you also, you want to make sure that you do an occupational profile on the patient. And then the quick dash and the dash assessments are two of the commonly used ones out in practice today, especially with outpatient. Um, so, that's why you're learning how to do that, just in case, you ever have someone with a shoulder injury. So, for the OT interventions, for the day 1 to 4 to 6 weeks, the goals of this phase are normally to help the client manage pain, reduce inflammation and edema, reduce muscular inhibition, and to promote resumption of select occupations. Some exercises or some occupations won't be able to be performed at this point, when in the initial phase or the acute phase of of healing after a soft tissue injury. Um, Health literacy is very important for the shoulder, so that the patient understands what they can and cannot do. And with health literacy, you always want to focus it to the patient's level of understanding, and use layman's terms when you're talking to a patient about it. The next stage is going to be your remodeling phase or your mobilization and repair phase. This is usually starting at about 4 to 6 weeks, depending on the level of injury. The goal of this stage is to gradually transition the client to being more active and resuming light activities with the impaired arm. Um, Next is your return or reintegration phase. This normally starts at about 8 to 10 weeks. Um, and this is going to be your reintegration into doing full occupations as much as possible. Okay. So the OTA's role. What is the OTA's role? One role for the OTA is to give your clients the tools and the education to remain independent despite their shoulder pain and immobility. Um, the psychosocial impact of a shoulder injury, or any type of chronic pain for that matter, but especially a shoulder injury, because the shoulder is so complex and it's involved in so much of your daily activities. Um, it's going to have a pretty severe psychosocial impact on a person. It can lead to depression. It can lead to just not doing anything, not going anywhere. So that's why it's important to get in there and give them some tools that they need to remain independent. You want to problem solve with the client on some tasks that may be difficult for them, some that require assistance. Will Oh, sorry, let me back up. You want to talk to the patient about the assistance that they're going to need, um, for their shoulder injury, and kind of help them problem solve through that, so that they may be able to perform these certain activities independently and require a lot less help. The more that you can do that, the more that you can provide them with that information, or those tools, the more encouragement they're going to have and the more hopeful they're going to feel. Um, some helpful tools for shoulders would be your anything long handled, shoehorn, elastic shoelaces, dressing sticks, um, The dressing sticks are good to pull up like bra straps or to pull up pants. Um, you need to also pay attention to the depression. If the depression seems to be worsening, then talking to the client or the caregiver and maybe to your referring physician, referring the patient to their physician for depression would be more appropriate. So basically, in a nutshell, that is your shoulder. Like I said, we will be doing some actual hands-on activities with the shoulder. Um, and if anybody has any questions or anything like that, Professor Dendler and I are more than happy to answer whatever you have, whatever questions you have, and that's it. Look at the different muscles and know the movements, and the location of some of these muscles. I know we went over this in kinesiology. If you took kinesiology from me, we go through each individual muscle and we palpate it, and learn where it's at in the body. So it just makes it a lot easier to treat and makes it 207 a lot easier, this class a lot easier. So that's it for the lecture. Again, if you have any questions, feel free to reach out. Bye.